So it's my pleasure to present to you folks the results of the ATOMIC-AHF trial, which is a phase 2 dose-finding study of intravenous omecamtiv mecarbil in patients with acute heart failure. The omecamtiv mecarbil is a novel selective cardiac myosin activator that has many characteristics that are potentially beneficial compared to currently available agents such as dobutamine and milrinone. I won't be able to go into details of its mechanism or these effects during this conversation, but I'm happy to address it later. The study design of ATOMIC-AHF as a phase 2 dose-finding study was much more complicated than the phase 3 studies that you've seen here. It's a randomized, double-blind, placebo-controlled sequential cohort with 3 cohorts of ascending doses where patients who present with acute heart failure, recognizing that acute heart failure is one of the leading causes of hospitalization in the world, were randomized, these patients who presented with acute heart failure were randomized in a 1-to-1 fashion to intravenous omecamtiv mecarbil or placebo, which they received for 48 hours. The patients were carefully monitored during hospitalization with symptom assessments, extensive pharmacokinetic sampling, intensive cardiac troponin and CKMB monitoring, and there were some patients who participated in echocardiography sub-study. Vital status of all these patients was followed at 6 months by phone call, and we have not completed that follow-up at this time yet. So this is the primary efficacy endpoint of ATOMIC-AHF. And while it was a dose-finding small study, we decided to go ahead and look at the potential effect on dyspnea, not really, with the trial not truly being powered to fully assess this efficacy. Nonetheless, we observed a progressive increase in the dyspnea response among the omecamtiv mecarbil treated cohorts compared to the pooled placebo in a numerical improvement that was not statistically significant, so a p-value of 0.33. Interestingly, if you look at the paired analysis, which was a pre-specified analysis of the placebo to the specific cohort of omecamtiv mecarbil, the placebo group has a 37% response rate here compared to a 51% response rate in the omecamtiv mecarbil cohort 3 for an overall treatment effect of 41%. That's a p-value, a nominal p-value of 0.03. This is supported further by the significant dose and concentration relationship between the increasing doses and increasing plasma concentrations correlating directly with increasing improvements in dyspnea. In addition, a secondary endpoint of improvement in worsening heart failure also trended in the positive direction with p-values ranging from 0.06 to 0.08 in the cohorts 2 and cohorts 3 populations. None of the other secondary endpoints were significant. The post-randomization adjudicated events allowed us to see that 30-day mortality and all-cause rehospitalizations were comparable between the pooled omecamtiv mecarbil group and the pooled placebo groups. And myocardial infarctions were rare during the trial, with 3 being in the placebo group and 7 in the pooled omecamtiv mecarbil groups. As I mentioned earlier, there was intensive, of a level that's never been performed before in a clinical trial, evaluations of troponin serially at multiple time points. The troponin change from baseline is compared here in the pooled placebo patients to the 3 cohorts from the omecamtiv mecarbil group. There appears to be a modest increase in troponins in the omecamtiv treated patients. This is a difference that probably would not have been actually detected by older troponin assays. Interestingly, we looked at this and tried to decide what its impact was, and there was absolutely no relationship between the increase in troponins and the omecamtiv mecarbil concentrations, either when evaluated by peak omecamtiv concentration or by the area under the curve total exposure during the 48 hours of infusion. So we saw no relationship between omecamtiv mecarbil concentrations and these mild increases in troponins. The main purpose of the trial was as a pharmacokinetic study and pharmacodynamic study, and in fact the signature pharmacodynamic characteristic of omecamtiv mecarbil was observed in the trial with a highly significant improvement with increasing concentrations of omecamtiv in the systolic ejection time, which we have shown in other studies to directly correlate with improvements in myocardial performance. So in conclusion, ATOMIC-AHF met its overall objective for providing information to go forward in phase 3 doses and providing information in terms of how to inform those specific dose selections. And now I'd be happy to address any questions that you might have. Thank you. No questions, okay. I know Steve's got some.
Hi, Steve Stiles, theheart.org. Would the troponin elevations been predicted by the preclinical work and the other early clinical work? Was that an unexpected finding?
It was an unexpected finding, but one that we wanted to be sure of and look for. We are not sure what to make of these very modest low-level differences, though. And we are a bit assured because there's this absence of any correlation with plasma concentrations of the drug at all, make it more likely, though we can't establish this through this trial, that it's more of a chance finding than it's actually mechanistically related.
And was there a correlation between the MIs and the troponins?
No. Well, yes, there was a correlation between troponins and MIs, since troponins, most of the MIs were actually diagnosed not by the clinicians. And this is an important aspect. Those MIs, because we were looking so carefully at troponins, we would look at the troponins centrally, and if we saw a troponin that went up, we called back the investigator and said, hey, do you think there was an MI? They had to fill out a form that then went to the clinical events committee, and the clinical events committee said, we think there may have been an MI here. So many of the myocardial infarctions were actually troponin triggered and not clinically.
Okay.
Did that help?
Yes.
Okay. Oh, sorry, you're running.
Bruce Jansen from Cardiology News. So is this endpoint dyspnea on the Likert scale, is that self-rated?
Yes, it's a patient-reported outcome that is, were this to have been a phase 3 efficacy trial, which it is not. And the important thing is to say here, this was not at all powered to actually look at this. But when you're having a phase 2 dose-finding study, you go ahead and look at these efficacy endpoints. But yes, it is a regulatorily acceptable patient-reported outcome.
Is that as good as it gets? I would think if you had acute heart failure and you felt lousy, it might be hard to separate your feeling of improved dyspnea from all the other ill feelings you have.
Well, about 90% of the patients who present to the hospital with acute heart failure are presenting because of their dyspnea. It's remarkable. You'll see patients walk around with these legs that look like tree trunks and barely able to walk. And you say, how long has that been going on? And they'll come back to you and say, well, that's been going on for 7 days. But the thing that's brought me into the hospital, the thing I need is relief of this shortness of breath.
Okay.
So it's a reasonable symptom endpoint.
Yes. Last question.
Okay. Did you look at effects on renal function from the drug?
We've not fully analyzed those data yet, so no. We will be, though. But once again, this is a very small study. The good news is we feel very confident that we found enough information to inform going ahead to phase 3 and with this compound. Thanks very much, folks.
So thank you very much.